Hello, everybody. Welcome to this part 2 of prostate didactic lecture series. So in this particular part, I'm going to talk about the grading of prostate cancer. And there has been many grading systems, but one of the most widely utilized and adopted grading system is the Gleason grading system. So I'm essentially going to talk about the contemporary Gleason grading for prostate cancer. So this particular system was introduced by Dr. Donald Gleason in 1966. It has many important differences compared to other traditional grading systems. One of them is it is based on low power architectural features instead of the nuclear features. It uses the sum of most prevalent and second most prevalent pattern to derive the score. So you have 5 patterns from 1, 2, 3, 4, 5, which will derive the score that can range from 2 to 10. It is one of the most robust and independent prognostic marker that is utilized for treatment decisions, specifically active surveillance versus definitive treatment, and is an essential parameter in various multivariate prognosis and outcome models for prostate cancer. So more than 50 years since its introduction by Dr. Gleason, this system has tested its time and has remained as the most robust prognostic parameter for prostate cancer. So you may argue that I think if that is the case, then why we really need a more contemporary approach to grading of prostate cancer, Gleason grading for prostate cancer. So I think this slide shows you important differences when Dr. Gleason described this in 1966 versus our contemporary practice today. In 60s, needle biopsies were thick course. We were sampling only selected targeted areas of the cancer because cancers were more obvious. While now we are dealing with prostate cancer detection, which is primarily triggered by abnormal PSA or elevated PSA. We also use thin needle course. We use multiple extensive sampling from standard as well as from targeted areas from the multimetric MRI detected lesions. At the time of when Dr. Gleason introduced this system, there was no use of basal cell marker. So now we know that some of what he called grade 1 or grade 2 prostate cancer in modern day would essentially kind of potentially would represent an adenosis or adenomatous hyperplasia. And then at that time in the grading system, he did not describe how to address the new entities, variants of prostate cancer. He also did not address in terms of tertiary patterns for prostate cancer. So these are like all these fundamental differences which has triggered to modify the original Gleason system developed by Dr. Gleason. There are 2 major modifications that occurred. The most significant modification was introduced in 2005. And then recently more significant, other significant modifications were issued in 2014. So these resulting modifications of this Gleason grading system has also been referred to as an ISUP or International Society of Urologic Pathologists Modified Gleason Grading System. This system has key definitional and operational changes. Definitional changes define each grade, while operational changes specifically tell you how to grade in a specific type of circumstances or situation. So I think I have some rules that I would like to address to you that I think can be helpful to you to when you come to GU rotation in terms of how to apply some of these rules. So rule number 1, keep in mind that Gleason grading remains, even in the contemporary approach, a low to mid power exercise because we are using low power architectural features of the tumor to determine the grade. If you start with a higher magnification analysis, then likely you are going to overgrade the prostate cancer. So stay away from 40x to determine the grade of your cancer. Only rarely you would go to high power to determine whether you are truly dealing with some fusion or that. Second rule is that even though Dr. Gleason conceptually and theoretically is correct that I think grade 1 and grade 2 prostate cancer exist, it's because of its modern changes in the practice pattern. We know that now if you call grade 1 or grade 2 prostate cancer in needle biopsy, then you are likely going to be significantly undergrading a prostate cancer at the time of radical prostatectomy. So in modern times, we do not use grade 1 or grade 2 in contemporary practice of prostate needle biopsy reporting or analysis. So our rule number 2 is that Gleason grading essentially starts with pattern 3 in biopsy specimen. Grade 1 and 2 you can rarely use in a transurethral specimens or radical prostatectomy specimen where you have the whole tumor to look at it. But due to its misleading implications, we do not want to use grade 1 or 2 in prostate biopsy setting. So essentially your grade is going to start from pattern 3 onwards, and this is the classic pattern 3. Pattern 3 is characterized by variably sized cancer glands which are discrete. You can draw a circle around each of these glands because they are discrete glands, and the variation and infiltrative nature is also a quite good characteristic of pattern 3. So this is classic morphology. Keep in mind that there are a lot of variations or sub-patterns that can occur within the pattern 3, which you should be familiar with. Sometimes the tumor can be sparsely distributed versus very dense back-to-back, which can be a pitfall in terms of overgrading. Its sub-patterns can also be based on architecture such as atrophic glands, branching glands, mucinous fibroplasia, which is not always pattern 3, but frequently it is pattern 3. And then certain twin-like morphologies and pseudohyperplastic cancers are graded as a pattern 3. So let us see some examples of that. Here is an example of like small, somewhat atrophic looking glands, which creates like a poorly formed gland appearance. And we will talk a little bit later that if you see truly poorly formed glands where tangential sectioning is ruled out, it represents pattern 4. But these atrophic glands, even though creates an appearance of poorly formed glands, you do see lumina, well-formed lumina in these small glands. So this is not pattern 4. This is still microacinar atrophic pattern 3 morphology. Pattern 3 sometimes can have branching U-shaped, Y-shaped type of glands that should not be overinterpreted as evidence of fusion, and it represents pattern 3. Mucinous fibroplasia, we talked about that in the part 1 lecture, that this is one of the specific feature of prostate cancer. But this particular feature can produce sometimes complex architectural patterns within the cancer, which can mimic as a cribriform pattern. It can mimic as a fuse glands. So when you deal with this particular morphology, you have to extract this particular feature from your analysis and then grade based on the underlying architecture. So most of the time it's going to represent pattern 3, but sometimes it can produce quite complex architecture like this one. So I would consider this as evidence of some 4, but I would not call cribriform pattern 4 when I see this type of mucinous fibroplasia prominently displayed. Pin-like prostate cancer, we talked about in part 1 that there are certain cancer morphologies which can be mimicked as a benign condition. So here, pin-like cancer characterized by this large branching kind of undulated glands resembling high-grade pin. But the thing is that I think here these glands are quite crowded together. So when you see this type of significant crowding of pin-like glands, you have to think about pin-like prostate cancer. Another helpful feature here is that you have a elongated stratified lining epithelium, so somewhat ductal-like morphology. And when stained, these glands entirely lack basal cells, and internal control has a nice strong basal cell staining in benign glands. So peen-like prostate cancer is characterized by resemblance to high-grade peen, but crowding and lack of basal cells. It should lack cribriform morphology or papillary morphology. Those two morphologies are not allowed for peen-like carcinoma. And sometimes it can have rounder acinar type of nuclei. So it has two phenotypes, peen-like ductal and peen-like acinar. But because of its potential misinterpretation as a ductal adenocarcinoma, you do not want to use word peen-like ductal. Just essentially, this would be regarded as a peen-like prostate cancer, which has been shown in a limited series that it has a more indolent biological behavior and should be graded as a pattern 3. Here is an example of a pseudohyperplastic prostate cancer characterized by these large undulated BPH-like branching type of glands. So this can easily be mimicked as a benign condition, but when you see carefully, you do see some cytological atypia, and then sometimes you may find some conventional acinar morphology. When stained here with basal cell marker, it is entirely negative. So pseudohyperplastic cancer is always graded as a pattern 3. Sometimes that type of morphology may give you pseudopapillary architecture, which should not be overinterpreted as a pattern 4. Pattern 4 is also quite diverse. It can have a variety of more different sub-patterns, poorly formed, and we will talk about all of this in detail. So I will not spend too much time here in this particular slide. So our third rule is that when you have a discrete but poorly formed glands where tangential sectioning is ruled out is considered Gleason pattern 4. And then this particular criteria was introduced in 2005, modification of Gleason grading system. But this particular criteria, I have seen that it suffers from definitional ambiguity. It was not clarified very clearly that how to distinguish poorly formed glands from tangentially sectioning that can invariably occur when prostate needle biopsies is cut. So here is a nice example where you have numerous discrete poorly formed glands with no or barely recognized lamina. So when you have this type of morphology, there is no agreement. I mean, there is no disagreement that this is Gleason pattern 4 poorly formed gland pattern. But keep in mind that when you have cancer which is cut at various different levels, you are going to have some poorly formed glands within some of these glands. So that should not be necessarily interpreted as a pattern 4 evidence. Here is such example where you have some well-formed glands and some poorly formed glands. In this example, also you are dealing with a small focus, so you cannot exclude tangential sectioning from your differential diagnosis. And we did an inter-observer reproducibility for this particular pattern, and we observed that inter-observer reproducibility is quite low even within the experts, and we did find some recommendations that you can use to improve the reproducibility. Number one is when cancer focus is very small, don't overinterpret few poorly formed glands as a pattern 4. When you have this type of poorly formed glands immediately adjacent to well-formed glands, it's invariably due to tangential sectioning. So those situations, again, you do not want to call that Gleason pattern 4. Here is an example of raggedly infiltrating fused glands, which is an example of Gleason pattern 4. Here is an example of glomeruloid pattern resembling glomerulation. This is also another specific feature of prostate cancer. And I will talk a little bit more about this later on as well, that this particular pattern, particularly when you have large glomerulation, it may be misinterpreted as a cribriform pattern 4, which should be avoided. So our rule number 4 is that a major departure that occurred in 2014 modification is that now all cribriform carcinoma, irrespective of the size and contour of the gland, is considered Gleason pattern 4 or 5 if they are associated with necrosis. So there is no Gleason pattern 3 cribriform prostate cancer anymore. So here is an example of small cribriform glands, irregular infiltrating glands with multiple lumens, punched out type of holes. Here is an example of large cribriform cancer glands. Now, there is a robust evidence that where cribriform morphology or cribriform cancer morphology is present, it is an independent parameter for adverse outcome. It impacts decision for therapy. Patient with this morphology would be not a good candidate for active surveillance. Patient would need a more definitive therapy. It is also an independent predictor of various adverse clinical outcomes such as decreased progression-free survival, increased biochemical failure, increased metastatic or mortality risk. There is also evidence that when you are dealing with a Gleason pattern 7 situation, with a grade group 2 prostate cancer or grade group 3 prostate cancer, cribriform growth is highly predictive of postoperative metastasis and disease-specific death. So that brings up an important point that when you have 2 patients, both grade group 2 or 3 plus 4 equals 7, one with the cribriform pattern 4 and one without cribriform pattern 4, such as poorly formed glands, is there difference in survival or outcome? Should patient with cribriform morphology be offered radical prostatectomy while those without active surveillance, those without the cribriform morphology should be offered active surveillance? Based on this data, where a patient with cribriform morphology invariably did bad compared to grade group 2 or 3 prostate cancer without cribriform morphology, which did well. So I think that's an important question that still needs to be addressed thoroughly. But this brings up an important point that you do not want to miss the reporting of this particular morphology when it is present. And I will talk more about this as well. But in real life, I think you are going to face problems in classifying cribriform cancer glands. So if you look at the traditional definition of cribriform morphology, it comes from a word cribrum, means sieve-like glands. It is characterized by glandular proliferation of epithelial cells with distinctive spaces or holes in between cells, imparting it a Swiss cheese appearance, like these examples. However, it is not clear how to deal with the classification when you deal with complex fusion or papillary patterns. I talked about glomeruloid-like growth pattern, glands with partial or Roman bridging, complex mucinous patterns, which are known to create this type of pseudocribriform patterns. When you have proliferation around nerves, that can often create a cribriform-like proliferation. And then issues regarding small versus large cribriform glands. These are all the factors that can potentially affect the reproducibility for this particular morphology. So there has been a recent attempt to standardize the definition of cribriform cancer glands, particularly when it pertains to prostate cancer. So International Society of Urologic Pathology has issued a definition of cribriform cancer, prostate cancer gland as a confluent sheet of contiguous malignant epithelial cells with multiple glandular lumina that are easily visible at low power. There should be no intervening stroma or mucin separating individual or fused glandular structures. So I think a very important point to keep in mind that there should not be stroma or mucin separating with the individual or fused glandular structures. We as an expert urologic pathologists, a group of 27 urologic pathologists get together and did an inter-observer reproducibility study, used a variety of lesions that may be potentially classified as a cribriform cancer glands. So what we observed that the inter-observer reproducibility was only fair with a kappa of 0.40. So that means that there is still significant interpretational disagreement or challenges when classifying this particular pattern. Large cribriform glands had a better agreement compared to small cribriform glands. So we came up with consensus. So what we did, we came up with 13 different morphological we analyzed 13 morphological features and then correlated with the consensus classification in a blinded manner. And that gave us some morphological features that were highly reproducible for the classification of cribriform cancer gland, while some morphological features were highly reproducible for classification against cribriform cancer glands. So these are some of the criteria that may be helpful when you deal with this particular type of morphology. So some of the reproducible features for cribriform cancer glands include transluminal bridging, means the proliferation should be end-to-end, not only part of the gland. Majority of intraglandular cells are not in contact with the stroma, so there should not be stroma running in between these glands. There should be lack of intraglandular mucin, same like ISUP consensus definition criteria. A clear luminal space along with the periphery of the gland should account for less than 50% of the gland circumference. So like a clear space like this should occupy less than 50% of the gland circumference, and that will be better represented in the next slide. And then the proliferation is usually typically dense in nature. Sometime in a very large cribriform glandular proliferation, you may have stroma that run in between and branch out the cribriform glands, but that this is still reproducible for cribriform classification because you still have a tumor which is divided into multiple cribriform branching glands. Here are some of the morphological features which are reproducible against cribriform cancer classification. In this example, you see partial bridging. So there is a good amount of proliferation creating a pseudo-cribriform architecture, but this luminal proliferation is not end-to-end. There are a lot of missing part within the proliferation within the gland. So this is classified as a pattern 4, but not cribriform cancer glands. Here you have stroma or blood vessels running constantly between the cells. So even though this is pattern 4 papillary pattern, this is not cribriform pattern 4. And we talked about glomerulation, which can, particularly large glomerulation, which can mimic cribriform cancer gland, but this is the criteria which I was talking about, that when you have a peripheral luminal space accounting for more than 50% of circumference with only one point of attachment of epithelial proliferation, that is considered glomerulation and not cribriform. And we talked about Mucinous fibroplasia in earlier slide as well. This is always a no-no for cribriform cancer classification. There are some studies which have looked at in detail different morphologies to predict the outcome for the prostate cancer. This is a study that I would highly recommend you to look at it by Dr. Jesse McKinney, who looked at a variety of these different architectural patterns and correlated with the prostate cancer outcome. And a similar study which have looked at specifically different architectural types of contemporary Gleason pattern 4 have shown that glomerulation and mucin fibroplasia / extravasation do not represent high-risk patterns. So even though they can create a cribriform-like appearance, we don't want to classify them as a cribriform cancer glands, and it is important to separate those two out. Another important point that you want to keep in mind that the cribriform cancer gland and intraductal carcinoma, which is essentially a retrograde spread of high-grade prostate cancer, they are highly interrelated morphologically as well as from clinical significance point of view. Both are independent adverse prognostic features. Majority of intraductal carcinoma also present with cribriform morphology, and both associated with aggressive molecular features. And that prompted many experts that why, if both have a similar significance as well as frequently similar cribriform morphology, why we need to separate them, and instead we may just consider them as a cribriform architecture. And this is a point of a little anxiety as well as the challenge within the pathologist, that whether they need to separate intraductal carcinoma from cribriform pattern 4, and I will give you some guidance regarding that. But the two GU societies that we have, ISAP and Genitourinary Pathology Society, has somewhat different recommendations. I'm going to provide you the GUPS recommendation along with my way of handling this particular situation. So whether, I think this brings up the point that I think whether intraductal carcinoma when present should be graded or not, or in other sense, whether we need to separate it out from the grading perspective or not. So there are arguments for and against it. The arguments for includes invasive cribriform cancer and intraductal carcinoma, as I told you, have similar clinical significance. By separating it, there is a potential under recognition of aggressive disease. There may be a risk of significant overutilization of immunohistochemistry. This was not done when Dr. Gleason introduced the grading system, and subsequent many of the outcome studies have not separated these two out. And this provides us an opportunity for a more uniform communication to urologists and patients. While arguments against grading includes that if you include that as a grading intraductal carcinoma only or intraductal carcinoma with grade group 1 prostate cancer would be labeled as a grade group 5 and patient could potentially be cured. And no other organ system considers in situ disease as invasive. But keep in mind that even though the name sounds like intraductal carcinoma as an in situ disease, only rarely it is truly in situ disease. Most of the time, it is an invasive retrograde spread of an invasive cancer. So my philosophy is that most of the time you can include that in the grading and would not make necessarily any changes in your clinical significance, as these scenarios of in situ disease or grade group 1 with intraductal carcinoma are extremely rare. But that brings up the point that when we really need to stain them to separate it. So I asked that, are there morphological features that I can use to separate cribriform prostate cancer from intraductal carcinoma when present? And I have talked about this in your part 1 lecture, that how you can utilize morphological features sometime to confidently separate between the two. And if I cannot have, or if I do not have those morphological features, then do I need to use basal cell immunohistochemistry? Will that distinction will be clinically meaningful and necessary? So here are my suggestions where you should utilize basal cell markers to separate between two by documenting presence of basal cells or absence of basal cells. When you have a lack of definitive infiltrative carcinoma with a suggestion of intraductal carcinoma, so when you are potentially dealing with intraductal only type of situation in the biopsy, when you are dealing with a setting of a low-grade infiltrative carcinoma where documentation of intraductal carcinoma is necessary to correctly assign the Gleason score to case, we will see the example in next slide. It is not recommended in the setting of already high-grade prostate cancer, where you think that by separating it is not going to change the clinical management or significantly grading. Then you can refer to those as a prostate cancer with intraductal features. So here is one such example where you see these small, well-formed atypical glands, which may represent grade group 1 prostate cancer, while in the background you have several these large atypical branching type of dense cribriform glands, which would be morphologically looking more like intraductal carcinoma. But in this type of situation, if you do not do basal cell stain, then you would have to call this 4 + 3 = 7. But if you do basal cell stain and document that these are intraductal carcinoma type of glands, then you can refer to this as a 3 + 3 with intraductal, extensive intraductal spread or intraductal component. So you can see that by basal cell staining, you can document the presence of basal cells around these atypical dense cribriform glands. So they do in fact represent intraductal carcinoma component. Patient might have an unsampled higher grade component, but for our purpose, I think we have to call this 3 + 3 with intraductal carcinoma with a comment stating that the significance of this intraductal carcinoma component is one of the pathological adverse feature, and patient may have unsampled higher grade cancer. At least this type of patient should not be offered active surveillance management. So here is an example of a ductal adenocarcinoma characterized by papillary and cribriform morphology with tall pseudostratified lining epithelium. You see some slit-like architecture, and this type of tumor grows within pre-existing ducts or spaces. So you may have presence of some basal cells around these ducts, which should not be interpreted as an intraductal carcinoma. But this is a nice example of a ductal adenocarcinoma of the prostate, which is graded as a pattern 4. Here is an example of a non-ductal but papillary morphology. So whenever you see true papillary morphology, you typically grade this as a pattern 4. Gleason pattern 5 is also a diverse pattern characterized by many morphologic patterns, infiltrating cords, single cells, solid sheets, Comedocarcinoma, and linear arrays and solid nest pattern. So let's see some examples of that. Here is a sheet-like or large nest-like pattern. This is pretty characteristic for a high-grade pattern 5 prostate cancer. Sometimes you may have some luminal formation within a nest or sheet-like areas. That's still considered okay for the grading this as a pattern 5. We have done a separate inter-observer reproducibility study for pattern 5 with different morphological patterns, and we observed that this type of occasional luminal differences were still pretty reproducible for classification as pattern 5. Here is an example of cord-like pattern, and you can see some desmoplastic stroma, which is a pretty bad sign, as I said earlier in the part 1. Here is the single cell pattern with numerous single cells and small cords. Here is a Comedocarcinoma pattern. But keep in mind that more and more, if you have a Comedocarcinoma, if you stain with basal cell stain, you may in fact document the presence of basal cells. So Comedocarcinoma is in fact more common with intraductal carcinoma component. So if you are dealing with primarily this morphology, then I would recommend doing basal cell stains to separate that whether you are dealing with primarily intraductal morphology or pattern 5 morphology, because it could potentially change your grade significantly. When you see signet ring-like cells in single cells or nest pattern, that is has a high reproducibility for pattern 5. Now, our rule number 5 is that grade based on underlying architecture for following morphological variants or variations: foamy gland adenocarcinoma, mucin secreting adenocarcinoma, gland forming adenocarcinoma with Paneth cell differentiation and intracytoplasmic vacuole. So in any of these morphological patterns, you have to use the underlying architecture to determine the grade of the tumor. Let's see some examples. Here is an example of prostate carcinoma with mucinous differentiation. You have numerous lakes of mucin. Previously, experts used to classify this as an example of 4+4 prostate cancer, but that is not true. Here, majority of these glands are discrete, floating individually within pools of mucin with some fused glands. So this is in fact an example of a 3+4 or grade group 2 prostate cancer, not an example of grade group 4 prostate cancer. Here is an example of a gland forming prostate cancer with this Paneth cell-like metaplasia or Paneth cell-like change. That should not be overinterpreted as an evidence of a small cell neuroendocrine differentiation. It is a form of a neuroendocrine change, but it is not associated with specific adverse prognosis. So you have to grade based on underlying architecture of the tumor. Example like this would be 4+3=7. Rule number 6, do not grade the following morphological variations: small cell neuroendocrine carcinoma, adenoid cystic, previously known as a basal cell carcinoma, and squamous and adenosquamous carcinoma are not graded. because of their specific therapeutic implications. So you do not want to provide the Gleason grade in this type of context. Here is an example of small cell neuroendocrine carcinoma. Patient with this is considered to be a very aggressive form of cancer. The patient would require a platinum-based chemotherapy. Typical standard androgen deprivation therapy may not be effective in this patient. So again, important not to grade this. This is from my book, where you can use these decision points as a guide to determine the grade. And this is one of the kind of flow chart that is available in that book. You may argue that with all these things, we should have perfect system, but that's still not true. Even with these contemporary modifications, there are some problems with the current modified grading system. Number one is, since the Gleason score 6 is the middle of the 2 to 10 numerical scale, patient often assume that they have a moderately aggressive cancer, despite the fact that that's the lowest grade that we apply in prostate biopsy. Gleason score is often grouped into 3 tiers for prognostic and therapeutic decisions. Gleason score 6, 7, and 8 to 10, 7 representing intermediate group, 8 to 10 as a poor group. But now we know that there is a significant difference between Gleason score 3 plus 4 versus 4 plus 3, and 8 versus 9 to 10 have significantly different prognosis. So to address these limitations, Dr. Gleason, Dr. Jonathan Epstein and colleagues introduced this new grading system of grouping the Gleason scores into 5 groups. Gleason score 6 representing grade group 1, 3 plus 4 as a grade group 2, 4 plus 3 as a grade group 3, 8 as a grade group 4, and 9 to 10 as a pattern 5. They call this grade group 2, but then subsequently this system was also endorsed by ISUP, so they refer to these as an ISUP groups or ISUP grade group. Again, I think in American literature, typically you are going to find grade group as a standard form of implication to designate a particular tumor. But keep in mind that this is really not a new grading method. It is essentially a grading based on the modified grading system, a novel way to group the Gleason grades. It is not a specific criteria by itself to determine the grade. The importance or the advantage of this particular grade groups now has been validated and shown in many cohorts, showing nice clean separation of individual grades into discrete stratification. In addition to this distinct stratification for prognostic purposes, other advantages includes lower number of categories, 5 versus 10 with the standard Gleason system, and the fact that the lowest grade is 1 and not 6. So our rule number 7 is that report the grade group along with the Gleason score, mandatory CAP reporting element. An example is shown here: prostate adenocarcinoma, Gleason score 3 plus 5 equal 8, grade group 4, prostate cancer. And again, I think if you are practicing in America, typically it would be referred to as a grade group. This system has been also endorsed by WHO and has also been endorsed by AJCC Cancer Staging Manual. So I think a reporting of this element is quite important. I talked about a lot of these modifications. They have been further updated, and these 2 papers that I would strongly recommend reading and keep a handy resource is from 2 white paper from GU Path Society, Genitourinary Pathology Society, and then also similar white paper was introduced by International Society of Urologic Pathologists. There are many similarities, but there are some differences which I try to address in earlier section. And they also provide reporting recommendations, specifically reporting related to cribriform and intraductal carcinoma morphologies. Now, some reporting rules. You need to provide percent pattern 4 for specifically grade group 2 and 3 prostate cancer. It has implications for active surveillance and radiation therapy, to add androgen deprivation therapy or not specifically. Small amount of, keep in mind that if you are dealing with a very small amount of Gleason pattern 4, typically 5% or less than 5%, it has similar outcomes like Gleason score 6. So when you are struggling with a very limited amount of pattern 4 versus pattern 3, I think it is prudent to utilize a more higher threshold to call something poorly formed gland pattern 4, because the significance anyway is not distinctly separate. And by putting that into grade group 2, you may make the patient ineligible for active surveillance treatment, while the patient may in fact be eligible for patient surveillance treatment. I think this particular rule applies when you are dealing with a non-cribriform type of pattern 4 morphology. This should be reported in increments, typically less than 5% or 10%, and thereafter further increments of 10%. When cancer focal is small, I do not provide pattern 4 because it could have misleading implications, because you cannot accurately estimate percent pattern 4 in that setting, particularly also when I deal with a tumor primarily at the edge of the biopsy and you are dealing with very poorly formed glands. I may not provide the grade, or I may not even provide the percentage estimation, because that can be inaccurate. Now let's talk about some of the rules regarding radical prostatectomy grading. So prostate cancer, when you examine radical prostatectomy, you will see that it is typically a multifocal disease characterized by multiple independent nodules. In this type of setting, typically the largest nodule is also referred to as a dominant or index tumor. It is typically highest grade and highest stage tumor. In this type of setting, when you are dealing with this type of obvious situation, you call the overall tumor 4 plus 4 equal 8 and do not dilute by combining these other patterns. So in this example, you have a clearly dominant index tumor with the higher grade tumor. So just report the dominant nodule in this type of setting. When you are dealing with two codominant nodules of similar size, you have to again not combine these patterns to give a diluted score, just score the highest separately identifiable dominant nodule. That will be your total overall Gleason score. Rarely you may deal with a non-dominant nodule of higher grade. So in this type of setting, each major tumor nodule should be graded separately. But again, you should not combine the tumor nodules to derive the score. So our rule number 9 is that map all the tumor foci, but we have a typically whole mount prostate. So I strongly encourage all residents to map the entire area of the different tumor foci. If you are not dealing with the whole mount, then you can use this type of mapping diagrams to map out the whole tumor. That can help you to determine the location, the dominant versus non-dominant nodule, and you can easily determine the overall grading of this particular type if you use systematically this. So strongly recommend to map the tumor, because if you don't do that, you could be essentially sometimes not able to determine correctly the score. So map all tumor foci to determine the index tumor. Do not dilute the grade by averaging grades of different independent tumor foci. Some rules about the tertiary patterns. So when you see this tertiary pattern in higher tertiary pattern in biopsy, you never use the word tertiary pattern. A situation like this where you have primary pattern of 3, secondary pattern of 4, and higher tertiary pattern 5, you combine the primary and the worst pattern to derive the score. So an example like this is 3 plus 5 equal 8. But in radical prostatectomy, when you see less than 5% of pattern 5 in the setting of grade group 2 or 3 prostate cancer, you have to refer that as a minor tertiary pattern component. So our rule number 10 is that in a biopsy setting, any higher tertiary pattern should be reported as a secondary pattern. For radical prostatectomy, tertiary pattern is applied when less than 5% of pattern 5 present in the setting of grade group 2 or 3. If you have more than 5% pattern 5 in this setting, you have to call that and combine that as a secondary pattern to derive the score. So this is an important rule as well to keep in mind. For example, in radical prostatectomy, Gleason score 3 plus 4 equals 7, grade group 2 with minor tertiary pattern 5. Pattern 4 is 20% and pattern 5 is 3%. So here it is clearly tertiary pattern. If pattern 5 was 10% in this setting, then you would call this as a 3 plus 5 equal 8 because that becomes a secondary pattern. So with that note, I thank you for your attention. I have talked about these two resources in my part 1 lecture, so I will not repeat it, but these are very handy resources available to you. I have put tremendous energy to create this educational channel, so please make a use of it. Subscribe to the channel. You will get periodic updates from the channel, notifications, and I hope that you will be able to use these didactic lectures as a guiding point during your next rotation. So with that note, I thank you for your attention.